So just we might start. There'll be a couple more people joining us, but it looks like we've got quite a few already. So welcome everybody to the CHA webinar series, The Guiding Lights, Expert Perspectives on Palliative Care and End of Life Support webinar series. We've been running this now for over 6 months, and we've had some fascinating monthly presentations, and I think it's gone really, really well, to the point that people are really keen. So next year we will plan to continue the series, probably from about March. I also acknowledge that Peter Jenkins, we couldn't, for technical reasons, we couldn't get on. So he will obviously be included in our next series as we go forward. So something to look forward to as we further develop this, but this will be the last for this, for 2023. And so, and just one more housekeeping thing, just so that everybody knows that this is being recorded. It will be put up onto our web, probably, hopefully, by the end of the week, including Philip's slides. So, without further ado, I would like to introduce Dr. Philip Good. Professor Good is a specialist in palliative care medicine. He's very passionate about seeing that his patients have the highest quality life that is possible, and he's got a particular interest in researching palliative care patients, patient care experience, and palliative care for people from cultural and linguistically diverse communities, which is something that's been raised over the last few sessions that we've had, how different some of these care modules have to be. Philip is the director of St Vincent's Hospital Palliative Care Unit in Brisbane, which offers both inpatient and home-based care. He also actively pursues his research interest in palliative care medicine, and he's currently appointed as the Associate Professor at the Mater Research Institute. So Philip is going to discuss palliative care from a specialist perspective, and we are incredibly lucky to have Philip come along and agree to this. And I know that it's a huge commitment on your time, Philip, so huge thanks. I'm going to disappear off the screen and leave it to you to put up your slides, and I'll come back at the end. So welcome, Philip. Very much appreciate this.
Thanks very much. So I'll just share my screen there. Yeah, thanks very much for the invitation, and yeah, hope we can have some questions and time for discussion at the end with all that. From that point of view, I'm going to talk a bit, I know this is with LDAC, I am going to talk a bit more about home-based care or community-based care, and just really about how different models of community specialist palliative care influence patient outcomes. And yeah, I work at the St Vincent's Private Hospital in Brisbane and Mater Health Services from that point of view. So, you know, I think home-based care or care in the community is a real privilege that we get to work in palliative care, and whether that's in people's homes, aged care facility, independent living unit, wherever they are pretty much out of hospital, is a really privileged aspect from that point of view. So one of the things I want to talk about is just about how our models influence people's choices and where they end up having care or dying from that point of view. And one of the often quoted thing is this Grattan Institute report, which suggests that 60 to 70% of people want to die at home, yet few do so. And at the time, that's almost 10 years old now, but in the next 25 years, they said the number of Australians who die each year will double as such. And the evidence is that home-based palliative care increases the chance of dying at home and reduces symptom burden without impacting on care or grief somewhat, although the evidence is not as strong as you might think for that. This is just a graph of looking at where people die depending on different countries. And it's interesting that, you know, if you look at places like Cyprus and Croatia, they have very high home death rates. So often, if you look at where do people in the sort of palliative care area, this is people with cancer, and it's obviously palliative care is more than cancer, but this is just one study looked at people with cancer and how many people die at home. And you know, in Australia, people sometimes think there's a high home death rate, and people sometimes quote high home death rates, but there's very few published high home death rates in palliative care services in Australia. So I think that's one of the things that can come out of this, is that if people are providing services, whether it be in residential aged care or in palliative care or community care, probably need to provide a bit more data about people actually dying at home, because that's not really there as such. So this looks around the world, and as you can see, there's a huge variation there, 18 to about 45% or 48% in Italy, with different selected people with advanced cancer. And if you look at the Australian ones, it's quite low, although I'll talk about a few areas that we've been involved in. So although that wasn't included in this graph, this is actually a study from Western Australia, which looked at the chances of dying in hospital, out of hospital. It's looking more about the impact of community-based palliative care and utilisation, and this is from Silver Chain. And so when you look at it, they had a 49.1% death rate out of hospital, which is, you know, as far as I can see in Australia, is the highest published home death rate. You know, interestingly, I don't know if anyone's here from Silver Chain, but I know that in the Senate inquiry many years ago, they said the home death rate was 75%. But if you look at publications, the highest home death rate published is this one, which is 49% from that point of view. And a lot of this is about models, I think, and about how you position where people want to go. So if you look at, you know, what makes a really good community palliative specialist palliative care team, and these people did a qualitative study and looked at what are the themes that are really important, and they're things like specialized expertise, 24-hour, 7 days a week, and that's really important, but still not available to everywhere in Australia. You know, the importance of communication, the importance of response, the importance to both physical and psychosocial and spiritual management, the importance of peace and fulfillment. So that's things like spirituality, and advocating for patient preferences and education. So this is where I work at St Vincent's in Brisbane, which is on the river, and the basis for our community palliative care team. Our inpatient palliative care unit is actually on the third level of the middle building there, which goes across both sides there, and it's actually got 40 beds, and it's quite a large unit, not always full. This is our community area that we cover, which is the Brisbane City Council area, and that's just sort of for ease of being available. So we basically cover the Brisbane City Council area, and the way there's another map, and it just sort of, those dots, although the dots aren't, the dots are actually where the nurses live, I think, but this is where people are brought up into sort of different areas around Brisbane, and it's somewhat even. You can see there's a lot more density in the middle than there is from that point of view. So what I wanted to talk about is we've done these collaborations with a few different private health insurers, and that's enabled us to look at what does it look like when you have a certain model, such as Bupa, which is a fee-for-service model. Then we did a collaboration with Medibank, which had a capitation model for the first year, but now it's changed to a fee-for-service model, and a public model, which you could argue is a capitation model where you get a fee for occasions of service, and present data for 1 year of those three, and also 5-year data of Bupa, which we've been going now. We've actually been going with Bupa for about 7 years now in a fee-for-service model. So sometimes it's hard to describe the differences between all these models, but essentially it goes somewhere like this, where a patient gets referred. The referrals come from hospitals or general practice, and it's probably about 50-50 still that we get this. This is in the community, and the patient gets referred, they get seen at home by a nurse or a nurse and a doctor, and then there's exploration of what the patient's care needs are, preferences, and choices. So along with that is that if patients need admission to an inpatient unit at St Vincent's, they can be admitted directly. Generally, there's a slightly caveat there from a public point of view. And if they need extra intensive care, intensive support at home in the last few days, one of the things we try and do is put that in place for people to be able to do that at home if they want. And some patients get discharged if they stabilize over time. So we're aiming to have a comprehensive 24-hour, 7-day-a-week service for patients, both in the community and in inpatients as well. And the team consists of a number of clinical nurses. We don't have a nurse practitioner at the moment. We did it this one stage. There's doctors, which are specialists and trainees, allied health available, and there's a sort of a case managed approach to patients from a nursing point of view, depending on the area they are. And there's also equipment available. Queensland's fortunate to have very good equipment service, although even with that, with some of the private health insurers, they even have a bit more responsiveness if you want from equipment. So we're fortunate from that point of view. And then there's also something we've implemented, variability across these services depending on what's available. Is what's called assisted nursing, which is when people have more involvement at home in the last sort of 24 to 72 hours of life, they can come and stay at your house for anywhere between 3 and 12 hours, especially being used overnight. So just to describe some of these services, so the Bupa program is patients with Bupa hospital insurance and generally a prognosis less than 12 months, although it's not strict in how we do that. Obviously, it's very hard to tell people what prognosis is at 12 months. Obviously, they need to have a clear diagnosis in terms of prognosis. There's no cost to the patient, and it's case managed again with a nurse with probably a lower case ratio than the public service as funded service as such. So Medibank, initially when the first year of this was people who have Medibank hospital insurance. There are a few different things about this. It was very much people who wanted to be at home and to die at home. So they very much had to have a clear wish for that. And again, no cost to patient and case management, but it was a fixed fee for the service they're on. So it didn't really matter if they're on the service for 2 days or 3 months or 6 months, you still got the same amount of money from Medibank. We did in St Vincent's. And the Queensland Health funded program, again, there's no cost to the patient, case management on more patients to nurses, and the prognosis is advanced progressive disease based on symptom needs. So again, there's not a prognostic cutoff. There's really no prognostic cutoff for any of these except for the Medibank one, which had to be people who are getting towards the end of life and wanted to be at home. So the way we tried to just to get a bit of a comparison between all these ones is that when people start on the Bupa program, we try to have a comparison with what's called the standard cohort, which is the next patient admitted to the service, to the public service as such. So yeah, just to go over the funding, initially the funding for Bupa was a fee for service. Medibank was a set amount per patient until admission until death or discharge, and a penalty for admission to a St Vincent's hospital facility. Interesting, that's all changed now, and it's actually now fee for service as well. So we're actually just coming to the end. We just finished the first year of the fee for service program for Medibank, so it enables us to look at a different model again from that point of view. And the public program is a fixed amount for overall service and broad targets around occasion of service, which we go massively over the occasions of service as such. So the Bupa data, if you do want to read about it, we actually published a while ago now. Just can't remember how long ago it was, but these are just to go through this from the Bupa data, and we can look at the Medibank one. So in the first year, there was 130 people in the Bupa cohort, similar mix to your standard cohort as such. From that point of view, the ages were pretty similar, living alone pretty similar, days on service pretty similar from that point of view, and the percentage of malignant, non-malignant diagnosis. As you can see, slightly higher alive patients, slightly higher discharge patients from Bupa, and slightly similar people have died as such. So then if we look at what was the 1 year data for the Medibank patients, and again, similar age as such, I guess slightly less people living alone. There was actually less numbers in this one, and that's because it's a more selective service, and interestingly had less malignant patients with malignant illness compared to the standard cohort as such. And it probably reflects that can be hard prognostically sometimes to work out when people with a non-malignant diagnosis are getting towards the end of life from that point of view. So if we just go back to the Bupa cohort and have a look at that, and looking at some of the things which I found really interesting about this is the final preferred place of death. So as we talked about the fact that that if you look at the Grattan study, people quote all the time 70% of people want to die at home. Well, it actually turns out that there's been very few studies on people in a palliative care service and said, where would you like to die? So in the final preferred preference of place of death, it's really interesting how different these are. So for example, if you're in the Bupa cohort, you have 53% preference at the end to die at home, whereas if you're in the standard cohort, it was 31% as such from that point of view. So when you look at that, and then you look at the actual place of death, so the actual place of death in the Bupa cohort was 45.5% as such, and the actual place of death for the palliative care standard cohort was 25%, and that 25.7%, interestingly, is around about what the average would be, around the world for palliative care, and hasn't changed a lot over many years, it turns out. So in fact, when we look at, just going back, when we look at do people achieve their preferred place of death, they're actually very similar between the two, and that's got to do with what your preference is. They're both about 90% preferred place of death choice. So depends what you think is the important thing. Is the important thing to have the choice, and how does choice get shaped? And what this really showed to us was that actually, if you can provide increased services and provide the ability and the choice for people to be at home, then people actually do have a preferred place of death at home. But that preference is not 70%, it's more like 50%. So then if we looked at the first year of the Medibank, which is much more of a select group, so these are very much people who want to die at home. So if we look at that and have a look at how many people, these are the people who die as such. And so, for example, and as you can see, if you looked at this cohort, only a small number are alive in the Medibank cohort at the end of the year, where a standard cohort a bit more alive. But the actual place of death, for example, in the community was very high, 68%. So we're just writing this up and trying to get published, but it will be the highest home death rate of a service, although it's a very select group of people, I realise from that point of view, as such. But then again, if we look at what is your preferred place of death, so that, as you can see there, interestingly now, so this is done about 4 years or 4.5 or 5 years after this first cohort. And just by chance, it seems that the home death rate, the home preferred place of death, was actually very much higher in the standard cohort. And it's hard to know exactly why that is. We have made some changes, obviously, in the public program at that time, to try and help people die at home. And it's interesting here, you can see the preferred place of death is 97% for the Medibank cohort, which is not unexpected, because that's one of the things that actually coming on the service was to try and have preferred place death at home. But the actual preferred place death in the standard cohort is actually much higher in this now. It's actually 57%, which is a much higher rate. And interestingly, the home death rate of the standard cohort was much higher again, 43%, whereas the Medibank was 80%, which is very high as such. And then when you look at how many people achieve the preferred place of death, it's around about the same, 82 versus 35. Essentially, the only difference between these groups is where you prefer to die as such, from that point of view. So then this is looking at, let me just so I can, so this is the characteristics of the patients who, this is the characteristics of the patient who died. And one of the things about this is to highlight is the differences in these groups. So for example, the median time on service is 45, which is very similar between Bupa and standard. But when we look at the Medibank, you'll see the huge difference there. And that's really the actual thing that I wanted to highlight, is that how you set up a service really changes the people you get on the service. So the others will be very similar, I think, as such. But so just remember, 45 days on service. Interestingly, on the Bupa program, even after 5 years, it's a very similar one. So this is 5-year data as such. So this is trying to look at 5-year data of the Bupa. So I'll just try and see if I've got the Medibank. Just looking at that. If you look at the days on service, that's a top line. You can see the Medibank cohort days on service is only 13.5 days, so it's a much shorter time. And interesting, the standard cohort's a little bit shorter at 39, but the Medibank cohort's much shorter at 13 versus 45. And the Bupa cohort, we'll look at this anyway after 5 years as such. This is 5-year data. So in that time, we've had 779 people come onto the service. There's been some discharged, some readmitted. Obviously, quite a lot died, and a few alive at the end of the sort of 5-year period as such. So it's just a very strict 5-year period. So if you look over that time, some of the different characteristics, slightly higher non-malignant at the end compared to the first year as such. Length of stay is 47 days. So over that 5-year period, it hasn't really changed from the first year to the 5th year as such. It's 45 to 47, which is very similar, slightly more people living alone at home as such. And then if you look at, what's been the outcome of achieved preferred place of death, and that's 85%, which is high, but I think that's really focused on what people really want, where they want to die. So it's interesting that, the home as preferred place of death is 53%. So after 5 years, these are people who put their preference in and have a preference at the end. That's the people that put their preference in as home at the end of the 5 years. And so it's been pretty consistent at 53%. And home as the actual place of death is relatively consistent, 42%, which is quite high. And it started off about 45%. So it actually had a bit of a dip in the second year, and then it was higher again. So as you can see, if people are wanting to die at home, about 80% of people achieve their place of death at home as such, from that point of view. The other thing that we do within this is try and get some feedback, and we found this helpful in the fact that, one, people get sent surveys, and then they get feedback to us, and this is a satisfaction survey to some extent, but also people get to write stuff, which has been interesting. We've published a little bit around this as well.
I'm just chairing this webinar, sorry, but you can talk.
So the patients who are admitted to the Bupa program, there's two times course of this is the first 2 years and the second 3 years, but essentially, just to give you an idea about, it was a pretty good response rate overall. So you get about 27% of patients, which is not too bad, and 35% of bereaved carers, which, I guess if you're involved in this area, you're aiming for about 30%. It's usually thought to be a good outcome of people actually sending stuff back to you. So this is all paper. They get sent a letter, and they send it back in a return addressed envelope. And so this is from around about, and as you can see, if you have dark blue or light blue, it's satisfied or very satisfied, and there's a small percent of very dissatisfied and a small percent of dissatisfied. So in general, people are very satisfied overall about their experience, and they also give feedback about that when things aren't working right for them. And that's the patient, and the bereaved carer survey is very similar, very high levels of satisfaction, and some low levels of dissatisfaction from that point of view, which was also good to get feedback around about how we can improve the service. One of the things that I should have updated this a bit more, but one of the things that people, I don't know if it depends where you work, but everyone's keen now on NPS scores, and the overall score was 68%, and I think it's been pretty static around 60 to 70%, which is pretty good in the healthcare setting. I know that some people try and get a very much higher one, but within private health insurers, so this is just Bupa, to be honest, within private health insurers, most of when they do NPS scores surveys, they're pretty low as such. So from my point of view, what are the outcomes and lessons from this is that how you fund a program and how you select patients can really drive outcomes for good if you're aiming to have a higher home death rate. But what we're really aiming for is to give people a bit more choice. And there's quite a high home death rate with all programs. Obviously, there's a very high home death rate if you select people very much from that point of view. That one of the things that really makes a difference, and I didn't really go into that, but in this intensive bit where you have an assisted and nursing available to stay at home with people, initially in the Bupa model, it's also the Medibank model, but essentially it was the thing that made the biggest difference. So everyone initially who had AIN stay with them overnight or during the day for a 12-hour period or a 3-hour period, depending on what people wanted, all of those people were able to stay at home. After 5 or 6 years or 7 years of program, not everyone still stays at home who still has that, and sometimes that model is used a bit differently. But that also made a big difference in terms of people being able to stay at home. It was interesting about just the different funding models, and I guess it depends on which side of the fence you are on this. So some people think a capitation model is good if you're the funder because you have a set amount of money you pay. If you're the people on the other end who are providing the service, capitation has some risks in the fact that you don't want to, you don't want to use too much intensive resources and make a loss out of the whole thing, which I guess is what everyone's worried about all these. So we, if asked, and so what we do now with everyone is a fee-for-service model. And I also realized from an other point of view of the fact of the private health insurers, and I guess publicly it's a capitation model, but from private health insurers, it's a fee-for-service model, and that we think that works best. And that's one of the issues around that is the fact that if you look, say, for example, at the Medibank model in the first year, the reason there was much less numbers on it than they had Medibank insurance was that the risk was all ours. We had to select patients. We didn't want patients necessarily going to be on there for 12 months and maybe cost a lot of money from that point of view. So we were very selective around that. Having said that, it worked out fine for us. But we have a preference for a fee-for-service model, but also because we think that patients having earlier involvement in palliative care makes a better outcome overall. So the preferred place of death versus home death is interestingly of how that's different and how it's really shaped by the model you have. And I guess, again, that's not been so well published around Australia as such. You know, everyone talks about their services and their models and how great everyone is, but actually published data is a very different thing. The other thing is this broader effect on the program. And it's one of the things that was really important from the beginning. So, you know, when you have different models and different funding models, you can worry that some people will get a different service. And you know, from an equity point of view, that certainly worries us. And one of the questions that was brought up early on from nurses was about, you know, like why should someone have one amount of service because they have different funding and someone gets something different? So, I mean, it's hard. The only way to overcome that, one is if you're a private health insurer and you fund a model, you want to show that you're doing something different to what's available anyway. So, of course, you have to have a different model and a slightly different service. But my goal with all this has been to try and work out what has worked best and to try and implement that onto the public or Queensland Health funded model. And one of the things that really has helped us, and maybe one of the things that made the difference, if you look at that last year of the Medibank one and there's a higher home death rate, is that it's enabled us to really show the benefit of allied health more, enable us to show the benefit of AIN, so that's actually available to the public service now from that point of view. And it's really this question about what actually makes a difference. You know, does more case management make a difference? Does more intensive make a difference? I think a lot of it's a mix of what I think makes the biggest difference is having really motivated clinicians and nurses who are really keen on, really enjoy their job and really want to do the best for the patient makes the biggest difference from that point of view. So I might stop screen sharing there because that's all that I had, and happy to have questions and have discussion now. I think we've got some time for that, so that's great.
Oops. Thank you so much, Philip. That was amazingly informative, and a program that we've not, like a model that we've not had on this series at all. So it's really interesting. One of the things that I was thinking about as you were talking was, so obviously you're keen to have more people die at home with, you know, supported PAL care, but has there, in any of the studies, did they cost the savings to the hospital, you know, the public health budget? Was there anything in there? Because clearly people dying at home is a lot cheaper than people going into hospital.
Yeah, I think that's one of the big challenges in the health system is, like, if you make a saving somewhere, where does the money get saved and where does it to help out? So a couple of things come out of this which were unexpected, I guess, at the beginning. So I think when we first started this model with Bupa, it was a fee-for-service model, and the worry from the private health insurers, of course, is that fee-for-service doesn't have a cap, and so you just have this idea that people can over-service, which often is a criticism of private health. Now, interestingly, it turns out that over the 5 and 7 year period, the average cost from Bupa of a community palliative care patient in our program hasn't actually changed in the whole 7 years. It's been the same amount. The actual real benefit to us, which is interesting about, you know, to what makes the difference now, and I guess this is the skewness of healthcare funding, is that the Bupa model to us has really helped in the sense that, and this may seem counterintuitive, but it's actually massively increased our Bupa inpatient spend at St Vincent's from palliative care. And you might think, oh, well, how does that happen? You've got all these people dying at home. What happens is that you meet people earlier, and because you meet people earlier, they have the opportunity or option to come into a palliative care service, which is cheaper for a private health insurer than an acute hospital. and the patients prefer to come into an inpatient palliative care unit. And one of the advantages we have is that we don't have an emergency department. It's all direct admission. It's 24 hours, 7 days a week. So that's for appropriate people to come in. And if you want to, if that would be the second thing I would say about all this, is that what helps people stay at home is motivated nurses with access to things. What helps people die is smoothly in an inpatient setting is be able to access inpatient admission 24 hours, 7 days a week without having to go through emergency departments from that point of view. So in fact, from the money point of view, we get much more money from Bupa for the inpatients than we do for the community patients. And that's only because, as you said, the community patients cost less in general on average.
Yeah.
And the other interesting fact is that there's this thing about, so we have a cohort of patients who come into our inpatient unit who never go onto our community program. So they come from other acute hospitals and they come directly to the inpatient unit. And that percentage is decreasing over the years. But it turns out that cohort of patients cost the private health insurer the most, for whatever reason, for various reasons, is that they've often never had the opportunity for community palliative care. They've been in a hospital environment, they come into an inpatient environment and they never actually leave. And so they actually cost the private health insurer the most. So probably another lesson about this is the earlier you can have opportunity to be involved with community palliative care service, specialist palliative care service, the cheaper your overall spend will be in general from that point of view. So if you're talking about the public cost saving, we don't get anything out of that as such. But in the private, we do get out of that. We get more inpatients, which actually makes more money. I think we get paid quite well for the private, although that's going to even increase more because it's been very hard for the private insurers to actually do this out around Australia. And there's a variety of reasons for that. Is that our model in Brisbane's relatively unique in that we have a mixed public and private model, in the sense that we have public and private funding. Having said all that, the patients are treated the same, but generally community palliative care services are very much publicly funded models. And again, interesting to me is that there's been a real reticence to have privately funded models within that, despite the fact that if you look at inpatients, there's lots of inpatients, even in public palliative care services that are private, everywhere. But people worry that somehow if you have a private model, it'll show that it's very different, whereas we try and have a very similar model.
That is, that's really interesting. So your model is really just Brisbane focused. You're not doing any kind of rural, remote, in service like that way. Yeah.
No.
I mean, that's the real challenge of, being able to, help people who are really struggling out in the bush, so to speak. But that's it. So just one thing I heard you say, and I might have misheard it, was in the model, it's about having a 24/7 specialist expertise available. I think you had that on the top of your model. One of the issues that we hear about all the time is the limited access that our providers have to specialist expertise. And obviously in aged care, for example, workforce is just really challenging on so many levels. And then, the commission, the Quality and Safety Commission, now requires 24/7 RN presence within those. But I heard you say that one of the things of the success factor was having AINs available. Now, did I mishear that, or?
No, that was where they could go and actually stay at the person's place.
Yeah.
So they would go into the person's house and stay with them for a period of either 3 hours a day up to 12 hours a day. Often it's overnight, and often it would be the last few days of life to try and just support the family.
Yeah.
The upside of that is, of course, is the physical care that they can do.
Yeah.
The downside, and this is probably one of the missing parts, that the downside is that AINs can't give medications. So, and that's one of the issues that can come up. And so there is actually a missing element here where sometimes it would be beneficial to have RNs be able to do that, but that's a different cost level as well.
Very much so.
From that point of view, yes.
Interesting, because nobody has ever raised the role of AINs before, in this space. And I'm assuming that the RN would provide the medication, and then the AIN would stay for the evening, but the medication would have already been given, or it's happening intravenously, or I don't know, it's something like that. But that is something that, for the workforce is a huge benefit, to be able to support it. It's something I might take back to our LDAC team as well, because it's an area that we've not focused on at all. And yeah, that'll be great. Did you have much struggle kind of being able to obtain a workforce to support this, like AINs, or was it were they already part of your team?
They weren't part of the team, no, so they had to be trained. Slightly precarious workforce, I would say. And one of the issues is, I don't know if we ever didn't have anyone available, but because we're attached to a hospital, there is some flexibility, I guess. And we have struggled over the years just working out how to do that, because obviously they have to be available to work. They work overnight. Yeah. Usually overnight, they work overnight, and they do the physical care overnight, and it's just so the family can sleep. Yeah. And so initially it's been precarious, but then I think you try and find some people who want to work in that space, and if you can give them consistent work, that's really helpful from that point of view.
Yeah. No, I totally get it. Still a challenge, especially in aged care. But look, we might wrap it up now because we're kind of at the end of time. But Philip, that was an incredibly informative session, and I've learned personally so much from it that I can take to my further kind of colleagues as well. Thank you for your time. I know how busy you are, and it was a huge commitment on your part. So many thanks. And I joined from everybody here that's also on. Thank you. And we hope to maybe reconnect next year in our webinar series on a slightly different tangent, but yeah. So thank you.
Yeah,
and thank you to everybody. Thank you to everybody who's attended. As you know, this will be on our web, hopefully by the end of the week. So happy for you to see it again, for you to refer your colleagues to it, and any information that you need. The slides will be up there as a separate entity if you want to share it as well. So as I said before, this is the last in the series for 2023. Have a great Christmas, everybody, and we will be developing another webinar series for next year, probably by the time it takes to pull it together. And the topic, we will kind of spend probably January, February working through that. But please continue to listen. I hope these are useful. Any feedback, most welcome. Take care, everybody. Have a great December and a new year. Keep safe, and we'll see you in the new year. Take care. Bye.